This is the case of 60 years old male. He has jaundice. CT scan showed the mass of the adenopancreas with dilation of CBD. And USFNA was negative for malignancy, and it was made a suspicion of autoimmune pancreatitis. The patient has high level of IgG4 and quick improvement of jaundice with corticoid therapy. But in September 2015, an MRI and CT scan showed a cystic lesion of the tail of the pancreas, and the analysis of cystic fluid taken during USFNA was normal. The patient has complete regression of the pancreatic mass with the 50 milligram of azathioprine. And the last MRI in January showed an increased size of the cystic lesion in the tail of the pancreas with the mural nodule. And the patient is scheduled today for USFNA and confocal laser endomicroscopy.
So we have a large team here. We also have Christoph Dietrich near us and a large anesthesiology team. And we already started the examination. So the system that we are using now, it's a combination of a Pentax linear scope, and we have a large channel therapeutic scope. And then we have the Hitachi Ascendus system as the ultrasound system. And we are at around 50 centimeters from the incisors, and you already see the pancreatic body, and Anand is very kind and he can show that to you. We increased a bit, you can see that the resolution, so we can increase the image and look a bit at the pancreatic body. You see it's a bit inhomogeneous with some hyperechoic strands. And then we can look also, we can go towards the confluence and look a bit. You see that the penetration of the system is really nice. So if I decrease the image and play a bit with the settings of the ultrasound systems, now we can almost see the head of the pancreas almost towards the level of the uncinate. So it's really a nice image from the stomach here. So then we'll move a bit backwards towards the pancreatic body and again towards the tail. You see some lymph nodes now showing up. So yeah, we're moving a bit here, but you can see a lymph node which looks completely benign. So you see the hilum very well, a hyperechoic hilum of the lymph node. And we can again increase the image, so we can play a bit with the image and look at the structures. So what can we tell more about the pancreas? We'll try to go a little bit backwards towards the tail. Again, you see it's inhomogeneous. We don't see very well the pancreatic duct.
It's also very atrophic, which is really unusual for autoimmune pancreatitis. This is a completely thin, small, tired-looking pancreas. And you get this a lot of times after the steroids, it sort of deflates. And I don't know if it was a sausage pancreas before, but this is a very small, thin pancreas. The pancreatic duct is visible, which is a little bit unusual also for autoimmune pancreatitis, because usually it's compressed. But it's in there, it's just very hard to see.
Okay, so we'll try again. We'll start again from the B mode. So Anand was showing the pancreatic body, and you can now see here a bit of the pancreatic duct, a little bit of the duct towards the tail. You see there are some hyperechoic margins of the pancreatic duct as well. And if we torque a bit the scope, then you see the cystic mass. And then we discussed a bit here before if this part is a bit it's a bit worrisome. So it's either the pancreatic tissue or it has been described as a mural nodule. So but it looks to us
like external compression from sort of a little bit of nodule of pancreas, if you ask me. But it doesn't look like a typical, most of it is outside the cyst and not inside the cyst. So it's a little bit atypical for a mural nodule, I think.
And I'll try to measure again the cystic mass. So it's around 1.7, maybe up to 2 centimeters. So we'll try to measure it again and record that. And then what we can, yes?
excuse me, are you worried that this is a solid lesion that is actually a cystic and solid lesion rather than this being a mural nodule? Because at the end of the day, the pancreatic changes are not really typical of autoimmune pancreatitis, but remember that this patient is already on therapy and he responded. So we have a cyst and there is a solid component next to it. You agree?
Yeah, I think that's the point. The point would be if we decide to do FNA, we will probably need to FNA both of them. But until we do that, we can. Yeah, that's what I was trying to do. So until we do that, we can characterize a bit more. So I just started the usual Doppler. You see the color Doppler. So you see there are some vessels surrounding the cyst, but not much. And there are some vessels also inside the solid part. So the important thing is that you have to play a bit with the settings. If you increase too much the gain, then you get a lot of artifacts. So this is artifacts. Then you decrease the gain, and then you see you can examine the vessels. Then you can switch to the fine flow, which is it's a power Doppler mode. It's a bidirectional power Doppler. So you also see the direction of the blood flow. But again, you can see some of the fine vessels surrounding the cyst. So in order to characterize a bit more, again, with Doppler, you get a lot of artifacts, a lot of moving artifacts. So if I move the transducer like this, then you get a lot of, you see now you get a lot of flash artifacts. So you have to keep your transducer still. And then we will try to do a contrast examination, because one of the advantages of using contrast with low mechanical index mode is that you get rid of the artifacts.
So we'll give the SonoView.
Yeah, and
SonoView is ready.
Just wait a moment until I can change a bit. I think the system is already set up. I'll get from the. Let's try like this. So you have to be steady and keep both the cyst and both the solid mass in the image. So I'll try a bit to increase the gain here. So now you see both of them on the right side image. Let me see. You see the solid part here, the cystic part here. And the idea is to have only small signals here in the back. So you don't want to see anything in the pancreas. You don't want any signals on the contrast image. So I think if we're ready, we'll place the contrast. Yes.
Going in.
All, yeah. And then we'll start the counter. So now you see the counter, and I'll try to keep the transducer still. So now you see it's coming, but there's not much. So there is some contrast in the nearby field. So what we can do, we can increase a bit this one.
It looks like it's.
Yeah, there is contrast in the pancreas, but not in the not in the nodule. So you see the nodule is not enhancing at all.
Do you think it's a nodule or just a part of the residual part of the tail of the pancreas, which is probably atrophic?
Yeah.
Mimic a nodule.
It could be just a focal pancreatitis that's left over or something, but.
And if you have really low signals, then you can do the microbubble tracing imaging. So now maybe you see better.
There is no enhancement.
There is no enhancement here, so only some small artifacts here. So this part, sorry?
Good news, yes.
Yeah,
for the patient is good news. Yes.
Good news. So you see it again with the microbubble tracing imaging mode. So whenever you have only scattered signals and it's not much from the contrast, you can use this mode, and then you get a better feeling that this part is actually not enhancing. So the solid part is actually not enhancing.
That's good news?
Yeah.
I thought tumors didn't enhance.
Okay, can you move for the confocal examination?
Now we are at around. Yeah, we can show you the bile duct, but the bile duct is really interesting, and also the gallbladder looks very interesting. We can move at the bile duct, and then we'll move back for the confocal, or you want to see the confocal now, and then I'll show you the
I think it's better to do the confocal, and after we will change.
Okay.
Okay,
so
can you prepare the needle? Can you give the needle to the...
Mark, when you did this the first time, Adrian, at the
Yes.
first FNA they did they see all of this, or were these changes?
No, the US and the USFNA was not performed in my center. They was performed in other center, and the description was very short. It was just a single cyst and with a negative cytology, low concentration of CEA. And
the before scene now.
this was more often the description of the MRI about the mural nodule, which is probably not a mural nodule. Huh? Yes.
Yeah, so now you see we have the 19 gauge needle already in place with the confocal probe. You see the needle somewhere here. So now the question is if we should sample first, if we should look first at the cyst or at the nodule. So which one do you think we should take first?
No.
Yeah, so we'll take the cyst.
Maybe the cyst.
Okay.
Yes.
So we'll just place the needle in. Okay. And then
Do you preload the?
Yes.
yeah, it's
Yeah.
preloaded. Yeah. So now you can see the confocal. If I can move it a bit, you see the confocal fiber getting out of the needle. So now it's out of the needle.
Nice image.
And then you just slowly put everything on the cyst wall, and we'll start the confocal, and then we'll try to put it on the wall. You see maybe some tiny vessels. So the idea is to keep it a bit still and then try to sample different parts of the cyst wall. It's not the perfect image, but I think we can move it a bit. Let's try here maybe. Okay. So now you see some blood vessels. Sometimes it's difficult to get confocal images really fast, so you have to be a bit patient. The other thing is that you cannot stay in the cyst for a long time, really long time, because of the risk of acute pancreatitis.
Yes.
So we'll try to limit the examination on 2 minutes. But this is a lot of debris, I think, so it's not.
You have 61 seconds left.
Yeah. I know. The counter is the clock is ticking.
Adrian,
Yes.
what is the risk of pancreatitis? I mean, you were talking about pancreatitis. So what is the risk? Do we have
I
any
think
data on?
in the first studies it was quite high, I think, but the problem is that the number of patients examined with confocal is quite low. So I think the risk should be the same as FNA with the 19 gauge needle. So you have to take that into account that we're using a 19 gauge needle. So I'll try to move a bit the needle with the elevator, but
here we can exclude a serous cystadenoma because
it's
we
not
don't have
serous
the vascular network. Also IPMN because we don't have the finger-like projection, and
5 seconds.
yeah. It's difficult to get a perfect image, but this
Okay.
happens most of the time with solid masses. In a lot of cases, with solid masses, and also with
there is
cystic
no
masses.
sign of malignancy, and there is no black humps of cells.
Yeah.
And okay, if you can aspirate and to try to obtain a cytology and CEA and lipase,